Welcome to this webinar on dengue, and this is the third of the series of webinars that we've been holding in the since October of last year. We started doing the first webinar on dengue, talking about the Wolbachia for the control of dengue by Professor Cameron Simmons, and then we had the second one in January of this year. With managing the severely ill adult and child dengue patient. And this is the third one, and this one will be the impact of COVID-19 pandemic on a global dengue situation. This is all this is a prelude to the dengue forum that we're going to have from the 13th to the 15th of June this year. And if you can mark your calendars now, 13th to the 15th of June will be the dengue forum, and that will coincide with ASEAN Dengue Day, which is on the 15th of June. This year, we're trying to make the World Dengue Day also coincide with the ASEAN Dengue Day on the 15th of June. So that will be a step forward in getting World Dengue Day recognized. And I know that Cameron Rafiq from the International Neglected International Society of Neglected Tropical Diseases has been trying to get World Dengue Day on the WHO map, and hopefully we can get that done this year. And subsequent to that, we will be having our annual Asian Dengue Summit, which this year will be where we had the fourth one in Jakarta, and the next one will be in January of 2022. So hopefully we can pull that through, and hopefully that will be a hybrid program. So today we've got two speakers, and I've got my co-chair with me, Professor Lulu Bravo, who is from the Philippines, and I think she needs no further introduction. She's Emeritus Professor at the University of Philippines, and she's also she's also been the chairman of the Philippine Vaccine Foundation and a lot of other things. She's also a member of ADVA, which is the Asia Dengue Voice and Action Group. Lulu, would you like to say something?
Oh yes, Dr. Zul. This is something that we have been doing for almost how many years now? You know, dengue, doing webinars and seminars, and actually we used to say that dengue is a neglected tropical disease. But is it really a neglected? Because, you know, in the Philippines, we are the highest incidence of dengue you can find in the Philippines. And for us, dengue is such an important disease, and it has really created a lot of havoc, a lot of loss of lives, and even we do have the highest mortality for case fatality for dengue. And we are very much interested to know, at our point, what do you think?
Yeah.
Does dengue in this time of age, you know, 2020 with the pandemic, it's interesting to know what's happening to dengue now. What's happening in Malaysia?
Yeah, it's interesting. I mean, that's why we're doing this today, the impact of COVID-19 pandemic on the global dengue situation. Well, I'm trying to get the data because everybody is so busy now with the pandemic and with the vaccine rollout that the data is actually taking a bit of time to come to me. But my sense is that since the pandemic occurred, we've got less cases of dengue, and we've got less cases of severe dengue that goes to the ICU as well. So and the discussion that we're going to have today is whether dengue cases have gone up or come down during the pandemic, and how has the pandemic affected efforts in vector control, education, studies, and vaccination facilities. hesitancy. That's
Zul, before you go ahead, do you think the mosquitoes are also doing physical distancing?
Yeah, well, we don't know, but I don't think they are exposed to the information that we tell them, so probably not. Okay, Lulu, since let's have you introduce the first speaker. Then we've got two speakers today. One is from Singapore, and the other one is from Sri Lanka. So, Lulu, would you like to do the honors?
Oh yes, you know, she's a very pretty lady. I just met her at least tonight. But you know, Associate Professor Ang Lee Ching is a director of the National Environment Agency's Environmental Health Institute in Singapore and the WHO Collaborating Center. You know, she has spent 20 years contributing to building laboratory capability for Singapore's public health and developing tools and strategies for mitigation of risks. You know, Dr. Ang is also associated with the Nanyang Technological University. She has served as advisor to WHO for dengue and chikungunya surveillance and control. And she's the director of the WHO Collaborating Center for Reference and Research of Arbovirus and their associated vectors. Ladies and gentlemen, it is my pleasure and honor to call and introduce Associate Professor Ang Lee Ching. Over to you, Dr. Ching.
Can you hear me?
Yes, Dr. Ang.
Okay, good, perfect. Hi, thank you, Dr. Lulu. I will be sharing my slides here. Thank you for the invitation to speak for Singapore in this very important subject. Okay, you can see my slides.
Yes, we can see.
Okay, now, so I would like to thank the organizers for this opportunity to share the Singapore story and how COVID-19 has actually impacted dengue in Singapore. Singapore, as you know, has a dengue control system that we have been trying for decades to keep dengue incidence very low. The first strategy, if you see from the left side, is to keep mosquito population low at all times. So indeed, I think in Singapore, the mosquito Aedes aegypti mosquito, the main vector for dengue, is relatively low, especially compared to the past. But however, there's always transmission and there's often an outbreak. We get regular outbreaks in Singapore, and so we need to also break transmission. So these are the four pillars that we work on. Surveillance. On surveillance, we have cases, virus, vector, and weather parameters. And these are all input into models and for early warning system. And on a daily basis, on a regular basis, whether there is outbreak or no outbreak, there's a sustainable preventive control program. And these are risk stratified inspections. They include risk stratified inspections, scheduled inspections island-wide, and a lot of intersectoral collaboration, what we call the Interagency Dengue Task Force, comprising of many other agencies and the private sector, all coming together to tackle dengue together. When it comes to outbreak management, source reduction is important. We go around try to enhance our inspection, and at the same time, chemicals are then used for adult mosquitoes eradication, and of course the enhanced stakeholders engagement. We know that dengue control cannot be a single agency, or even cannot be you cannot rely just on the government's responsibility, but in fact it's a national responsibility, the whole community. So communication and outreach is very important. We have a lot of communication at the national level, or even at the same time at a specific stakeholder level. And all these are supported by legislation and research, as you can see here. If you want to read more about the Singapore Dengue Control Program, we have just published a paper on a greener vision for dengue control, for vector control, talking about Singapore's dengue control program, published last year with Professor Lindsay and Professor Wilson in PLOS NTD. in short, in summary, the program is aligned with the global vector control response framework that WHO has developed, which is strengthening inter and intra-sectoral collaboration and action. And we enhance our entomology and a lot of monitoring. I will share with you some of the data later on, and also to scale up, integrate our tools and approaches, and of course, engage and mobilize communities. So in 2020, we had a historical outbreak of dengue infection. It's the highest ever. The last highest was in 2013, where we got about 800 over cases per week at a peak. If you see the orange line, don't know whether you can see my cursor, but however, this year the peak just shot up to about 1,800 cases, the highest ever in history in Singapore. So, and we have 32 deaths as well last year, 2020. So what we have observed is that number one is what caused this outbreak. I will go through it. Number one is that we started with a historical high of the orange line, if you see, was the blue line, which was last year. And in the beginning of the year, we already started with about 300 cases per week. So as you start in the lull period, when you have a high number of cases, you would expect when the season comes that the cases will escalate even further. So number one reason is that Singapore, due to the reduced dengue infection through the years, have got very low immunity. So we are very susceptible. The population is very susceptible to outbreaks. If you look at over time, our seropositive, dengue seropositive, these are, in recent years, we have collected 4,000 blood samples from healthy residents from the blood bank each year to test them. And if we compare with the 1980s published data, we see a drop in the proportion of population with antibodies, suggesting that it is the vector control has been working for that. The vector control that has going on for decades have been working, but however, the irony is that the population has got very low immunity. If you look at all the different age groups, they have dropped in seroprevalence significantly. And in more recent decades, the last 1 to 2 decades, we see a continuous drop on the chart on the right side, on the top right. You see the different age group all continue to drop in their seroprevalence. So we can appreciate that the herd immunity is very low. And these are all, if you put all these data together, you will see the force of infection has been dropping through the years. So these are also published data. Sorry, I haven't got the reference here, published some years back. So number one is herd immunity. Number two, we through the virus surveillance, we can also see that what viruses have been causing dengue in Singapore. In Singapore, what we saw has been alternating dengue 1 and 2 pattern. In previous years, we got dengue 1 outbreak, and then a few years later, a serotype switch, and then you got a dengue 2 outbreak, and then you have a lull period. If you see the top graph here, the red color is dengue 1, and then when there's a serotype switch, you get dengue 2. Switch to dengue 2, and we got an outbreak. Okay, the black lines are the cases. The colors are the different serotypes. And the cycle repeated itself in 2013 and 2014 when we had another outbreak. And then 2016 was a switch to dengue 2 again, and then another outbreak. But unfortunately, the cycle was broken in 2019 when we saw a smaller outbreak compared to 2020. So we saw a 2-year outbreak. So two things has got changed here, the cycle, the pattern is changed here. Number one is that the lull period that we experienced from 2010 to 2012 was not repeated. Number two is that there was no serotype switch. 2016, we had a dengue 2 outbreak, and without a serotype switch, we continued to have a same dengue 2 outbreak again in 2019 and 20. So those are changes in the epidemiology of dengue in Singapore. And surprisingly as well is that you see the green and especially the green was emerging. The green color is dengue 3. Dengue 3 became a very dominant serotype in Singapore in 2020. Okay. So if we look at the variants of the virus that is escalating, the dengue 2 was due to mainly one specific strain, one genotype, which is what we call the cosmopolitan, is a cosmopolitan genotype, and what we name it clade 1b, and it was the cause of the outbreak. And on top of that, we had dengue 3, two dengue 3 clades emerging as well. Okay, and we know that. So these are some of the cause of the cases. Were the escalation of cases, we think it's because low herd immunity and an emerging virus as well. Dengue 2 cosmopolitan virus, we have analyzed the data, international global data, and it's found that it is the most epidemiologically successful genotype of dengue 2. It's spread across Asian, Africa, and Australian continents. Indian subcontinent and Pacific, so it's all over the world, and that's why it's named, right, cosmopolitan. It's mostly active in Southeast Asia, Far East, and Indian subcontinent, and has a very short and long-range dispersal network. So we know that it is a very fit genotype that has high epidemic potential. And in terms of dengue 3 and 4, if we look at the seroprevalence of Singaporeans, of Singapore residents in we see that these are different serotype. These are done by PRNT, where we have seroprevalence of different antibody specific or that react to different serotype of the virus. And we'll see that dengue 3 and 4, we are very susceptible. Our immunity is very, very low. Overall, among adults, this adult population of 16 to 50, only less than 20% of us had, less than 20% has had dengue 3 or dengue 4, okay, in recent years. So we know that we're very susceptible to these two serotypes. So I move on now to, so that was the virus surveillance, and I'm now moving on into the vector surveillance part. These are our gravity traps. To date, we have about 70,000 gravity traps providing near real-time surveillance in the whole Singapore. Every block of buildings, public housing, more than 80% of us live in public housing, the HDB flats that we call, and each block of flats would have about 6 of these traps to help in the monitoring of Aedes aegypti population. And we know that when the Aedes aegypti population is high, it is associated with dengue cluster. It has a higher odds of developing a dengue transmission. So these are our, what we call the gravity trap aegypti index. When it is, if it is low, if you reference to the low point, any increase, you will see an increased risk of transmission. So if you look at the number, 0.05 means 5 mosquito per 100 traps. And 0.1 is 10 mosquito per 100 traps. Okay. So these are very important data for us to understand the risk in the location, and these are even published in the high population area, are published in our ENV, our website, and our app as well, our ENV app, so that the community knows that they are living in areas with high population and they could take action. So this is empowering the community with mosquito data. So what we saw this year, compared, this trap has started since about end of 2017, and it sort of matured in 2018. But what we saw is that 2020, we had more areas with high number of high population of Aedes aegypti, particularly if you look at GAI 0.2, we have 20% more in 2020 than 2019, suggesting that more areas had higher population and thus susceptible, more risk of dengue transmission. So of course, you have the virus. We do surveillance for cases, and you have the virus that play a role. There's usually no magic bullet, like one single factor that affects dengue. It's often a multifactorial alignment of several factors that cause an outbreak. So we saw emergence of dengue 3 and 4, and we saw increase in area with high mosquito population. And at the same time, COVID hit Singapore in like everybody else, in 2020, early 2020. So we had a circuit breaker, what we call a circuit breaker, which is a semi-lockdown from 7th April to 1st of June. And around about 95% of workplaces were closed, including all schools and recreational facilities and all construction sites. So migrant construction workers were also quarantined in their residences during this period. So you can see the COVID cases in Singapore. To date, we have 60, and we have an average of about 13 cases today, but they are in the last 7 days or more than 7 days now, they're all imported cases. All right, so it's very well under control. However, we then started to examine whether COVID impacted dengue as well. If you look at the chart on the right side, as dengue was escalating, it sort of the escalation coincided with the circuit breaker period. Okay, and then in that period, some home inspection was reduced because of the measures, the circuit breaker measures, the lockdown. And at the same time, people were all working from home. Everybody was spending a lot of time at home. Instead of going to work in air-conditioned spaces, most of us were all at home, and until today, many of us are still working from home. So you can imagine Aedes aegypti being a day biter that hangs around homes in a built-up environment. The exposure to the mosquito could increase. So this is exactly what we saw. This is already published in the Journal of Infectious Disease, that we saw an excess during that period when we control by age group, the younger population and the older population, on which the circuit breaker had very, very little impact because they have always been home, using them as control group and adjusting for weather parameters. We saw an excess of 37.2% in dengue cases during the circuit breaker period. So as I mentioned, there are multi-factors that affect dengue in Singapore, in anywhere. So besides the virus, we have the vector, and now here, working from home, we believe increases the contact time between the population and the vector, Aedes aegypti. Interestingly, we also analyze and say, does it affect different population? We know that the workers were also quarantined in their workers' dormitories, and they had no access to construction work sites. And very interestingly is that the general population, when we analyzed, we pulled the data apart, we saw that in the general community, we have excess of a 63.5% increase, whereas the migrant workers actually reduced. And this, we think, is because construction site, we know, is a high-risk location, high-risk site for dengue transmission. And by not going to work at the construction site, the workers had a reduced risk. So these are very interesting data that we got. So in short, COVID impacted dengue by increasing it. I know Hasitha has a different story, so I'm very keen to hear from Hasitha in Sri Lanka. But in Singapore, we have found COVID to contribute to dengue outbreak in 2020. Now, I shouldn't end dengue talk without briefly mentioning our project Wolbachia in Singapore. Our Wolbachia project is relying on the male mosquitoes that carry Wolbachia, and when they mate with the female mosquito, the eggs don't hatch. So we should see a reduce in the population. So there were also people asking, so why is Wolbachia then not controlling dengue? because Wolbachia is on trial. They are very localized space, localized areas. So in Tampines and Yishun, where we were trialing Wolbachia, we in fact saw a localized impact in these study sites. Up to, we saw a reduction. If you remember the GAI, the Aedes aegypti index, we see an eraser effect from high GAI, and the black lines are the outline of places, areas that we have released Wolbachia, and see the Aedes aegypti population in these areas. Okay, very gradual, but they are decreasing. And we have also seen a reduction of dengue incidents in these Wolbachia project area. So because the area is small, it doesn't impact the whole country, but it has a localized effect. And this data is very comparable to what Malaysia saw using another strategy, the replacement approach, where they saw about 40% reduction, and also Yogyakarta about 77% reduction in dengue. So the suppression method seemed to be working as well as the replacement approach. In 2020, we extended Project Wolbachia to smaller areas, and after 3 to 4 months, we also saw a reduction in Aedes aegypti population. In this site, the areas are very small. There is no statistical calculation for dengue cases, but we saw a significant decrease in the Aedes aegypti population. So we're quite happy with the Project Wolbachia, and we will be expanding it. Okay, lastly, I would just want to acknowledge all our collaborators. It's a lot of, it's just 20 minutes or 30 minutes, but it's a lot of data and contributed by all the different groups and different ministry highlighted here. Thank you very much.
Thank you.
Okay, I will end here. Thank you.
Yeah. Thank you, Prof. That was very enlightening. We've got Singapore, has done an excellent job of controlling COVID-19. We're actually envious of Singapore. And the data on, the data that shows that you've got an increase in dengue during the pandemic is something that's interesting. I don't think any other country has reported that. And thanks very much for that bonus on Wolbachia project and updating us. It was very useful. Thank you very much.
Thank you.
We'll handle the questions at the end of the session. So I'd like to introduce the second speaker for today, who is Dr. Hasitha Tissera, who is an old friend of ours, and he actually is the medical epidemiologist leading the National Dengue Control Program of the Ministry of Health in Sri Lanka since 2013. And he joined the Central Epidemiology Unit in 2002 after serving as a regional epidemiologist in the very exciting war-torn eastern province of Sri Lanka. And now his responsibilities include national surveillance of dengue, coordination of dengue case management nationwide, and also training of all levels of clinical and public health staff. And he's also responsible for the technical evaluation of dengue vaccines registration in Sri Lanka. And he's a principal investigator of a number of international research projects on dengue. And he's also been a researcher at the London School of Hygiene and Tropical Medicine a long time ago. So with that, I'd like to ask Hasitha to proceed with his talk on the situation in Sri Lanka. All yours, Hasitha.
Thank you very much for inviting me for this presentation. As indicated in my my opening page, my talk is on a summary of what happened to dengue transmission during COVID-19 lockdown period in Sri Lanka. Next slide, please. I'll be talking briefly on dengue transmission during past decade, how Sri Lanka responded to COVID-19 pandemic at the initial months, what happened to dengue cases during the national lockdown period in 2020? What are the lessons we can draw for the future of dengue prevention and control in Sri Lanka? Next slide, please. So this is a map of Sri Lanka for those who haven't seen Sri Lanka or visited Sri Lanka. Infectious diseases are a group we are expected to conquer, of course. On the contrary, it appears that infectious diseases are dominating our lives today. Sri Lanka's strategic location, probably in maritime track routes in the Indian Ocean, with links to busy ocean routes and proximity to the subcontinent just 34 kilometers away, remain determining factors in infectious diseases from historic times. We have 21 million people living in approximately 63,000 square kilometers of land area. On the other hand, our relative physical isolation as an island from the subcontinent is a natural safety net from all infectious diseases, including COVID-19 and as well as dengue. Epidemic dengue was reported in urban areas for over 5 decades. But there were only occasional reporting of the most severe form of dengue hemorrhagic fever. DHF became endemic in Sri Lanka around 1989. And I'm showing you the climatic zones of the country. Sri Lanka has a warm tropical climate with 2 distinct rainy seasons. Month of May, the hottest period, precedes southwestern monsoon. Rains coming with winds from the Indian Ocean down below. From here. Between October to January, monsoon winds come from the north-east, bringing moisture from the Bay of Bengal. The country can be divided, therefore, into 3 zones on the basic climatic conditions. They are the wet zone, which is basically the southwestern part, including the capital city, Colombo, in the western province, and the central mountainous area, where an annual rainfall of around 3,000 millimeters occur. And then the dry zone, which covers the coastal belt, narrow in the east and south, and then fans out to the north, receiving an annual rainfall of about less than 2,000 millimeters. And then, of course, there is an intermediate zone between the wet zone and the dry zone, which belts between the wet zone and dry zone throughout. Next slide, please. Okay, this is a busy slide, sorry about it. From 1989 onwards, dengue hemorrhagic fever cases were mostly reported in and around Colombo. But from 2000 onwards, with multiple dengue serotypes circulating, DHF progressively spread to other towns other than Colombo in the other parts of the country, reaching outbreak proportions. From about 2009, where we had a massive epidemic in my slide, there were multiple epidemics with exponential increase in case reporting compared to the previous decade. There was a large epidemic in 2009 with an overall case fatality rate of 1%. There were 35,000 cases reported and almost 350 people died. With multiple actions taken to standardize early diagnosis and clinical management, overall case fatality rate came down to less than 0.2% by 2019, which means for every 1,000 patients reported, less than 2 people are dying at present. In 2020, there were about 31,000 cases and 36 deaths reported, something similar to what had gone with Singapore, which are considerably low figures for Sri Lanka. Next slide, please. In the epidemic year of 2017, the worst year on record, a community-based seroprevalence study was conducted by us in Colombo district. Overall IgG seroprevalence, that is seen on the left-hand side of your slide, was 72%. And the Colombo metropolitan area, where the age-specific seroprevalence rates were higher in children compared to the other parts of the district. And on the right side, we found this finding in seroprevalence was in keeping with the reported age-specific prevalence, where the metropolitan area had a model age of 5 to 9 years of age compared to the rest of the district, where the model age was 20 to 24, basically, which means that in the metropolitan area, the children were getting infected with dengue at a younger age, and there were symptomatic children as well at a younger age compared to the rest of the district. Next slide, please. This is a weekly graph, a famous graph in Sri Lanka, showing the seasonal dengue epidemics in Sri Lanka for 2019 and 2020. This data is collected using the routine surveillance system and sentinel site-based early warning system. That's why there are two parallel lines going in parallel, one preceding the other. In 2019, the mid-year peak was shifted to the latter part, with most cases being reported during November and December at the end of the year in 2019. This trend continued in 2020 with a total caseload of 11,600 cases reported in January 2020. This was higher than the number reported in January for the epidemic year 2017, where we had 10,927 cases. So this was the highest January in 2020 ever recorded. Considering this situation, it was expected for 2020 May-July dengue season to also be high. As an epidemiologist, I thought this is going to be worse than our 2017 year on record. On the contrary, the reported number of cases dropped drastically. In fact, the number continued to remain low today. These numbers, as you see at the bottom, are for 2021, and numbers are pretty low for 2021. Next slide, please. In Sri Lanka, a proactive top-down approach paved the way for SARS-CoV-2 infection to remain low during the initial wave in 2020. First local case of COVID-19 was reported on 11th of March. Subsequently, all schools were closed from March to July. From 19th March, Sri Lanka suspended all arrivals at the international airport except for repatriation flights where people were coming back from wherever they were working. An island-wide curfew was imposed from March to May. All non-essential staff were asked to work from home, but hospitals and public health services continued round the clock. Inter-district movements were restricted and public transport was available for essential services mainly. Areas where there were clusters of COVID-19 outbreaks were reported were immediately isolated with no movement in or out. However, the health services and essential items like food items and the drugs for long-term illnesses were provided to the community to their doorstep. Next slide, please. So considering the imminent dengue outbreak in the second quarter of 2020, with my epidemiological imagination, with the advent of monsoon rains, a care pathway was developed for fewer patients when they attend the OPDs of hospitals. OPDs were directed to have a predetermined area called the fever room to examine fever patients. Triage nursing desks was set up where the patients were registered and assessed based on the duration of fever, their symptoms, and subsequently, if phlebotomy is needed, phlebotomy was done before the examination by the OPD medical officer. Patients fulfilling COVID-19 case definition, as shown in this algorithm, were directed to an isolation area or ward in the hospital after the initial management, of course. While for those still the suspicion of dengue was not over, if there was any suspicion of dengue, those patients were directed for a rapid diagnostic NS1 and a CBC when required. Next slide, please. In 2020, compared to the previous 5 years, we saw a substantial reduction of dengue reporting in 2020. Island-wide incidence shows about 2.7-fold reduction, while the Western province, where most of the cases are reported annually, shows a 4.3-fold reduction. A reduction was seen in case fatality rate as well as mortality when you compare the population level deaths. Next slide, please. So an opportunity was created where the population-wide morbidity restriction imposed as a response to COVID-19 pandemic created an opportunity to evaluate dengue epidemic before and after mobility restrictions or social distancing, as called in Singapore. Dengue transmission during the first quarter and the second quarter of 2020 with that of preceding 5 years in all districts were compared. In addition, impact of mobility restriction nationally in the wet zone and dry zone and in the Western province were also evaluated. Further, impact of school closure on dengue among children to that of adults in the Western province were also compared. Next slide. We used reported national surveillance data and COVID-19 interventions published for the in-depth analysis of this paper or this presentation. Mobility data on the workplace and residential category were obtained from Google Community Mobility Reports available in public domain to demonstrate deviations in the mobility pattern during lockdown of the community. Impact of lockdown on dengue was analyzed using interrupted time series analysis designed by a junior colleague of mine who's pursuing his research degree at Umeå University in Sweden. Next slide, please. This is another map of Sri Lanka. Geographic distribution of average dengue cases for the past 5 years following monsoonal rains for the countries shown in this slide. In the first quarter, on the left-hand side, districts in the dry zone with rainfall from northeast monsoon from October to January saw more dengue cases per 100,000 population. This is the incidence slide. For the second quarter, the wet zone had reported more cases following the southwestern monsoon during May to July from 2015 to 19. What happened in 2020? With COVID-19 lockdown from mid-March, there was a ubiquitous island-wide reduction of dengue cases in the second quarter of 2020, as you see on your right side. Next slide, please. This is an interesting slide. This figure shows reported dengue cases in the wet zone during 2020 compared to monthly averaged dengue cases for 2015 to 2019. Green solid line that you see here is showing the 5-year average cases. The red dashed line is showing cases reported during 2020 up to July. The purple solid area is the period of extensive mobility restriction, and purple dash area is the indicated period of school closure. Pink area denotes the period of dengue outbreak control interventions that were done initially at the beginning of the year. Residential mobility and on top represent the percentage change of daily mobility compared to baseline residential mobility. Same with the workplace mobility. So what it means is basically the usage of mobile phones at home has gone up and the usage of mobile phones at workplace have gone down. This is a reflection that people were more at home during this lockdown period, and this is evidence-based. Average monthly dengue cases in 2020 started just above the 5-year average here in January and declined during February. It came down drastically, and thereafter during lockdown mobility restrictions, it remained low. It is noticeable that the expected July peak that we usually see every year is clearly obliterated in 2020. Next slide, please. In the dry zone, similarly, epidemic curve for 2020 started well above the 5-year average. As we saw, there was a huge large number of cases in January compared to the previous year in 2019, which spilled over to 2020. This decline, this trend declined during March and continued to remain low, relatively very low, even compared to the rest of the country. Next slide, please. If you look at the Western province, where most of the dengue cases are reported, at least at the beginning of the epidemic, Western province followed the similar pattern that was seen in the wet zone. It is noteworthy that the reduction for children was greater compared to that of adults in the Western province. So we compared the numbers for children versus the numbers that were reported for adults, and we see a drastic reduction in children as compared to adults. This may be a reflection of the prolonged school closures. Next slide, please. Meta-analysis estimates show that there was a statistically significant impact of mobility restriction on the reported dengue incidence in national, zonal, as well as provincial levels. At the national level, overall 88% reduction was observed. I haven't put the confidence interval because it will make my slides busy, but it was very clear that the reduction was significant. Impact on dry zone was more than that of wet zone. So this is unusual. There was a clear difference between the dry zone and wet zone. The reduction was substantially more in the dry zone compared to the wet zone. In the wet zone, the Western province, where the highest impact was observed among children, which is 92% reduction compared to that of adults. Except for one district at the bottom here, Ratnapura district, which had a local outbreak due to extended non-functional rubber estate in rubber milk containing milk collection containers, which started in February. All the other areas had a reduction in the second quarter 2020. Still, for Ratnapura, it was below the 5-year average. Next slide, please. Sri Lanka experienced the lowest reported dengue incidence in 2020 in the recent past. It was an enormous relief for the healthcare workers with the battle at hand with COVID-19. Reduced human mobility contributed to limited spread of dengue in Sri Lanka. This unique experience allowed us to observe how dengue transmission in different climatic zones behave, especially how reduced cases in the wet zone, which is the predominant area where outbreaks happen, influence greater reduction in the dry zone. Next slide, please. It is common knowledge, also discussed in many forums, and even published multiple times, that health-seeking behavior has significantly changed globally during the COVID-19 pandemic. Therefore, it is unrealistic to consider that dengue cases were not underreported, especially milder cases, which constitute to the majority in most countries, including Sri Lanka, and whether the surveillance system was functioning to the optimum level during the lockdown period in Sri Lanka as well. In order to make our data more realistic, it was important to address these possible limitations. So this slide is on that. We observed monthly hospitalization in one district in the Western province from 2015 to 2020. And we calculated the standardized incident ratio for the first and the second quarters of 2020 and compared with the other common diseases that are usually reported in hospitals. Despite lockdown, considerable hospitalizations were reported in the second quarter as well. Observed reduction, if you look at the observed reduction in admission, it is possible that it was due to altered health-seeking behavior during the second quarter. However, leptospirosis admissions, if you look at this slide, have increased by 2.5-fold, supporting our observation of continuous functioning in the integrated surveillance system in Sri Lanka. Consequently, the reduction of dengue was by 2.6-fold, which is more pronounced than the overall reduction in admission, indicating altered transmission dynamics with restricted human mobility or social distancing. However, was the observed reduction in dengue due to milder cases remaining at home and avoiding hospital was another question that we wanted to answer. Next slide, please. In order to test if the reduction in dengue was due to the reduction in admissions of milder cases, we compared the hospital admissions of dengue fever, the milder form, relatively milder form, and severe dengue or DHF in one major hospital from 2015 to 2020. It is clear from this slide and the table that the severe patients who deserve admission have come to hospital compared to the previous 5 years and the 5-year average. The numbers have in fact slightly gone up. Although there is a reduction in dengue fever, the milder form, patients in the proportion of that, it is within the random variation observed in the last 5 years. It has not exponentially reduced. It is within the normal random variable range that have been observed in the previous 5 years. Therefore, despite restrictions, considerable number of milder patients also have come to hospital for treatment. Although there is a reduction, it is not significant. Next slide, please. So in conclusion, ladies and gentlemen, year 2020 saw the greatest reduction in reported dengue incidents in recent times in Sri Lanka. We are cautious not to be overconfident about this reduction with a single year's experience, of course. Importance of a substantial, sustainable vector control strategy in public places, including schools, is a long-term utility of these findings, because comparatively it seems as if public places have a higher chance of infecting humans when they travel up and about during the daytime. Early detection of clusters for targeted acute febrile illness surveillance and vector control, considering human mobility, is an additional consideration from these findings for the future. Finally, a well-planned, wider serosurveillance system to detect mild cases and asymptomatic infections is also important. To this end, a collaborative project on household level spatial repellents with Notre Dame University is already being formalized. Next slide, please. I would like to acknowledge my co-authors in the paper that we have submitted for publication, Prasad and Joachim from Umeå University, Sweden, for the hard work in analyzing and interpreting the data and allowing me to make the presentation here. Dr. Ananda Amarasinghe from WHO Wipro provided substantial amount of inputs on this presentation. And this work has been submitted to PLOS NTD. Hopefully, they might accept this publication. Last but not least, I would like to thank ADVA committee for always inviting me for a talk, and especially Professor Dwayne Gubler for inviting me for this talk. Thank you very much, and over to you.
Thank you, Hasitha. That's very interesting. I think it's interesting that we've got two presentations from two island nations, and one of them actually shows an increase and the other one shows a drop. Lulu, what do you think of that?
Very interesting. And in fact, that leaves me something to crave for, which is what's happening in other parts. But definitely, this is fantastic. You have differences in the age group as far as the reduction or increase in dengue. You have differences in whether you are physically distancing or you are working from home, like what Professor Ang said, working from home could be a risk for dengue. Oh my gosh, I couldn't believe it. I've been working from home from the time the lockdown started. I wish I don't get dengue. But that's interesting. Thank you very much, Dr. Hasitha and Professor Ang. So I guess we have to really try to investigate, what does it matter that you are actually doing this? You are a construction worker. What is your risk? I think what our two eminent speakers could say is, let's put down the risk factor now in this lockdown. What are those risk factors that will give you, dengue? And the mosquitoes, oh my God, those mosquitoes, are they really real? That, where are they? Where do we find them now? This Aedes aegypti, are they at home, in school, in hospitals too, maybe, or even in construction work? As Dr. Hasitha says, they're out there. What are the risk factors now?
You want to go first?
Okay.
Please.
Well, in Singapore, we have published a paper showing construction sites are one of the high-risk areas. Presumably, it's difficult for housekeeping, right? It's a challenging kind of a place to do vector control. So it's an area that we pay a lot of attention. In fact, it has improved a lot in recent years, but we still see it as more high risk than other areas. And we also find more breedings, a lot of breedings are at home. So yes, home is a high area for us. For us, not the school, we don't have evidence of a school-based transmission. So mainly our transmission is home-based, perhaps some public spaces as well, but mainly home-based. So I think it's very different in different countries in terms of the breeding habitats or the high-risk areas for Aedes aegypti. Yeah, Hasitha, what about you?
Yeah, few things. One is that probably when people stayed at home, the essential services like the garbage collectors, they in fact worked quite diligently, I would say. I mean, they continue to collect garbage from towns all the time. I mean, during or the entire lockdown period, this was done. And people being at home, they were probably having less chance of littering the immediate environment also, because there was not much ice cream cups and yogurt cups to throw around. So there was a chance that they had less consumption of indulgence food, and probably there was less waste. But nevertheless, whatever waste that was there was collected regularly. So that was on one side. And probably because the schools were closed and the construction sites were non-functioning, there was little chance of initiating the outbreaks through humans from those sites and taking them from there onwards to other places. So that is what I feel had happened, but it's really complicated. I really don't know whether we can simplify it to that level, but nevertheless, it's really intriguing because these dynamics in different countries is really interesting, and we should study it more.
Yeah. In fact, for us, we also have more breedings. So we feel that, everybody was stressed, serious, you work from home, doesn't mean you're not away from your children. The children are also at home. So a lot of homeschooling, a lot of cooking, a lot of housework to do. So we think that could possibly also contributed to the increased breeding because housekeeping may take a second, maybe of lower priority because you have to homeschool the kids. Everybody is staying in that small little home. And most of our homes are naturally ventilated. They're not air conditioned, so they are then very prone to breeding if you don't take care of the water. Yeah.
I think I've seen in Thailand, especially in Bangkok, how it starts, the clusters in Bangkok and then flares up to other areas of Thailand. And same thing we observed last year in Sri Lanka because there was no epicenter there were no hotspots in the urban areas in the Western province, which would carry the infection to other parts of the country as people travel. Because travel and trade definitely has a huge role to play in the transmission of dengue from one locality to another locality and bring up another outbreak there. So simply 2020, because of the restrictions in movement from district to district, we didn't see inter-district transmission happening to that extent. So this is an important finding. I don't think we can use that as a control mechanism for dengue, but nevertheless, it is an interesting finding which can be used for our surveillance activities.
Actually, I think that's an interesting observation. It's that you don't spread. And Singapore being a small country, the spread is a lot easier, faster. And I think the weather also perhaps is a bit different between Sri Lanka and Singapore. You have a cool season, a real cool season, and we don't have. And I mentioned that even in the beginning of the year, the cases were already high, which means that the viruses are already in the community. So it didn't need that spread. The mobility didn't play that significant role. As in Sri Lanka, the incidence was very low, I presume, in the beginning of the year because of the cool weather in most parts. So the temperature, I think, plays a big role as well in the different epidemiology.
Interestingly, Ching, we see the same transition in the serotypes. And also the cosmopolitan gene is the predominant one in Sri Lanka for the last 3-4 years. And we are shifting to type 3 right now. We have predominance of type 3, which is going to have an impact definitely in the coming months, probably the next year or so. Because after 20 years, we are seeing the switch to type 3. Type 3 has not been there for almost 20 years in Sri Lanka. It was predominantly 1 and 2. And now 2 was predominant. The 2017 epidemic was mainly with type 2. And that's now replaced by type 3. And the type 2 that we had was the same cosmopolitan variety that you were talking about. The same thing, and it had come from China or Singapore, by the way.
So it's so interesting. We mirror each other. Dengue 3 hasn't been dominant for decades as well, 20 over years here. And this is new. That's why our herd immunity is very low for dengue 3.
We've got a question here for Hasitha, but it's not related to dengue. Are you willing to take that?
Yes, sure.
Okay, it says that.
As far as I can.
Okay, it says that she wants to ask for clarification on the leptospirosis cases during the lockdown period because you showed that it had increased. So, what do you think was the reason for that?
It's very clear. People were asked to go and plow the land because we are not working at the workplaces. They were asked. They in fact went to their hometowns, and everyone who's not experienced in plowing went to their fields and started working in the fields. And these guys who are not the regular workers are not given the prophylaxis when they go to the field. So they didn't know about the prophylaxis and they got infected while they were in the field. And majority of them were not experienced, farmers. They were just, ad hoc farmers who did it because they were staying at home and doing nothing. So this is the reason why we had a substantial outbreak of COVID. During the lockdown period, the leptospirosis was coming up.
But during the lockdown period, you'd expect that if they're working outside, they'd also be bitten by mosquitoes, right?
Yes, of course, but but they were not infectious. Probably mosquitoes were there, but they were not infected. Probably that is the case. So that's the linkage. That's the hint, because there would have been dengue mosquitoes, but unless they are infected, they would have not been transmitting the disease. Yeah,
that's right.
But unlikely in the farm, you will probably not get Aedes aegypti, right? It's probably some other mosquitoes in a farm. Probably
it's ubiquitous. Aedes is all over. Farms alike, but still, at least in the suburban and rural areas, where human habitation is there, we have seen both albopictus and aegypti to cohabitate.
May I ask, Dr. Hasitha, actually, I was so interested in the kind of severity now that you have a change of serotype from, you said, serotype 2, and now you're seeing more of serotype 3. does it impact on the kind of severity that you might be seeing in Sri Lanka? And the same thing maybe in Singapore. Do you find any change in hospitalization rates maybe, or severity of dengue cases that you have?
Well, I really don't know, because it's difficult to answer clearly about the serotype change. I can tell you in the past, in 2009, there was a clear shift in the serotype, a shift to type 1. And there we had a huge epidemic with 35,000 cases reported. In 2017, again a shift to type 2, from type 1 predominance to type 2, where there was a major epidemic. So definitely serotype change has an impact on overall dengue cases reported. Possibly the sequential infection has an impact on severity as well. Definitely.
Well, I think that the literature shows that dengue 2 and 3 possibly could be more, you have a higher risk of severity for secondary case, particularly I think there's 2 serotypes. So we haven't done the analysis yet in Singapore, but I think the serotype does impact the number of symptomatic cases that you see, so the number of reported cases as well.
Right. So, yeah, do you have other questions? You know, these are really interesting things, and maybe they will be published in other countries in Asia Pacific with high endemicity could really learn from this, as much as really looking into, you know, investigating and analyzing what it really takes to get those outbreaks and maybe prevent future outbreaks.
Okay.
But there's another question there.
Another question here. Has Singapore, this is for you, Prof. Has Singapore conducted studies about the co-infection of SARS-CoV-2 and dengue virus?
No, I don't think we have these cases reported. We had a case, we had published a paper as well on the cross-reactivity of the rapid test kit. I think 2 cases. So they are not on validation. They are not co-infection. Maybe one is still questionable, still a query. There was one, maybe perhaps a query, but it's not definite that there was a co-infection. So no, we haven't done any studies on that.
Oh, I have a question here. I got it from my email. And it says, what would be, Dr. from Sri Lanka, Dr. Hasitha, what do you think would be the role of dengue vaccine in Sri Lanka? And also in Singapore, I guess, because, you know, we do have at least 2 advanced phase 3 already, trials of dengue. What do you think would be the role and the possible future of dengue vaccines?
Ching, you want to go first?
I think as a medical doctor, it's more appropriate that you.
Okay.
Because yeah.
It's a tough one, Professor Bravo. It's a tough one, but I don't want to cast aspersions on dengue vaccines because I'm involved with the trial here with the Takeda vaccine. So it's going on. In fact, there are plans to evaluate after the second dose how to move forward, because we've now, I think, fast 3.5 years after the second dose and still being monitored, because the long-term monitoring is for 5 years. So, I mean, still too early to tell you exactly what's happening, but we are very much at it. Well, as for the other vaccine, the Sri Lankan authorities at the NRA decided to wait for more information before registering the other vaccine, the one from France. So we haven't registered that vaccine in Sri Lanka as yet. But, you know, we'll have to take a call on that as time passes. I mean, whether to register the vaccine or not is a difficult question again. Still, it's not very clear. So the French vaccine is yet to be registered, and that discussion is not on because we are, you know, hellbound with the COVID vaccination, and discussions are mainly on accessing COVID vaccination program and rolling it out. But definitely, I mean, it's an important question whether there is a place for dengue vaccine in this background, but it has to be deliberated. I think there is a need for more technical discussions before we come to a conclusion whether the dengue vaccine will have a place in this backdrop of COVID-19. So we will have to wait and see. I have no yes or no answer to you on that.
I think that a good vaccine will always be welcome as a person, whether it's private use or is it a national community use. It really depends on the vaccine data. But having said that, I think vaccine does not eliminate the need for vector control. So even with dengue vaccine available, vector control still have to go on because there is chikungunya and there's Zika. So yeah, I think vector control is an important aspect with or without vaccine.
Thank you. Over to you, Zul.
No, I think we don't have any more questions online. We had about 89 participants early on. So is there anything else?
No, we had the highest, I think, is more than 90. It's just keeps going up and down. Plus some of are in the chat box.
Okay.
Close to 100, Zul.
Okay. All right. Anything else that we wanted to? It's 9:20 now. I think we've.
Just a last point, Prof. Ismail. Just want to tell you that I see a lot of similarity between COVID-19 and dengue. I think it will be interesting if although it's a vector-borne disease and a contagious disease from the other end. I see. I mean, with my maybe I'm biased because I look at dengue in depth. But when you look at it on the whole, there are similarities and differences that go hand in hand with both diseases. One is that there are these both diseases are forming clusters. They spread in clusters, and dengue has very clear epidemic-temporal relationship when they spread. Among family members in close clusters. Similar way, COVID-19 we see clusters forming when there are super spreader events and so on and so forth. So maybe, as Ching said, vaccine alone might not be the magic bullet. We need to have other measures of control to be in place for both diseases to, see that we can manage them. I don't think of elimination as such in the near future, but to manage them, we need to, maybe take certain stocks from experience in dengue and try to apply that to COVID-19 as well. Thank you. Over to you.
There's a question here about whether MISC, the multi-system thing that's Kawasaki disease-like, could that resemble dengue shock syndrome? Any ideas on that?
I think you are the best person to answer that. Kawasaki disease and
dengue. Yeah. I think there's a difference between the presentation of MISC and the presentation of dengue shock syndrome. So I don't think there's a resemblance, and I don't think that people will actually make a mistake with diagnosing it. Okay, so we're done. So I'd like to invite Lulu to give her final comments since I made the initial introductions.
Oh, that's a surprise.
I just
you want the woman to give the last say? Last word?
Yes, it's always that way. I just want to remind everybody that we have a forum on the 13th to the 15th of June. And that the 15th of June is the ASEAN Dengue Day, which we're also going to make the same day as World Dengue Day. So over to you for your last words, Lulu.
Okay. Well, ladies and gentlemen, our distinguished speakers today, Dr. Hasitha Tissera and Professor Ching, actually gave us so much. I really did not expect so different, varied, but very interesting impact of the COVID on the dengue. I mean, it was something that I really did not expect, but I learned so much. And the risk factors and what's happening now, I think we will need to go further. This is something that I think most of you who are doing research might really need to look at. And even the mosquitoes, are they really becoming more intelligent than us in this way? That even in the time of COVID, right? There are countries that will have an outbreak, a higher increase, and in countries they will be decreasing. So something that we really need to tackle. But I really want to thank, we missed Professor Dwayne Gabler. He was supposed to be here instead of me. And Zul told me, you have to come in. You have to come in. And like a good soldier, you know, I cannot say no to Zul. So just about a few hours ago, he says, come in. You have to take the place of Professor. And I'm really honored to do that. So for our last word, it's really thank you. Thank you to our participants. Thank you to the organizers. I'd like to thank Francis Kwong and Matthew Mati who organized this, and of course Wilson Teo. They were all very kind of getting us last minute instructions for this. So tonight is another interesting night for the dengue fanatics. We are all here working together despite the pandemic, despite everything else. Thank you. And maybe good night to all of you.
Bye.
Thank you, Hasitha. And thank you.
Okay, good night. Thank you very much.
Good
Bye.
night. Thanks.
Ching.
Good night. Bye. Thank you.
Are we offline, Matthew?
There are more 50 people there that they can hear us, and we can say hi as long as you're there.
Yeah, I wish
But
there were
Hasitha, Professor Ching, thank you very much. Really, really fantastic talks. Never
Thank you.
expected that it would be something like that, you know.
Yeah, we didn't expect it.
Yeah, it's unusual. I mean, as you said, Malaysia also saw a drop, but we saw an increase. Yeah, I just wonder about other countries. Actually, I was very tempted to post.
I was hoping that other people would chip in, but nobody else from the other countries chipped in.
Yeah,
we can send a call to places like Vietnam and Laos and see what their response would be like.
Yeah, and Brazil and I thought really it's a tricky disease, right? Because there's so many factors. So if you have different temperature, you have different size, the impact is different already.
All right.
Yes, indeed.
And I guess also for us when we go home, it is a lot of urban. It's all urban setting. Whereas in Sri Lanka, going home may mean less exposure.
Rural sort of setting.
More at the farm. And,
Okay.
Yeah.
Very much, all of you.
Matthew, we're off, right?
Yes, you're off. People are still in the room. There are still a few people here, some 20 people.
They can hear us.
So they can hear you, yes.
And
so
they're welcome to put in their comments, actually.
Yeah, they should put in their comments. We'd like to know what's happening in Vietnam.
Those still remaining here. In fact, they can chat with us.
yeah, okay.
The night is still young,
Yes.
you know.